continuing developments, both on the preclinical side and the 1100 data that we'll be discussing today. So with no further ado, I'd like to introduce the CEO and founder of Nanobiotix, LAURENT LEVY.
Thank you, Jeff. Can you switch to the slide, please? Thank you. So, thank you everyone to be here. I'm happy to see this large virtual crowd. We've built this company because we think we really have the potential to change the life of millions of patients. And we want to do that by using physics, by bringing the nanophysics into the heart of a cell. When we started this technology, we're going to develop that a little. We looked at how people are treated when they have a cancer and found out that 50% or more of all of them have or receive radiation therapy during their treatment. And what we see is you can't cure all the people receiving radiation therapy because there is some time, some limitation due to this technology. Just as an example, if you can't deliver the right dose in the tumor to kill the tumor, then you will have an issue. And nevertheless, radiation is used in all the big solid tumor. And what you can see is, in some cases, you have problem when it's not possible to have the right dose to have the right local control. If you can't have that, sometimes patients can die from local invasion of the tumor, or they could die from the spread of this tumor coming from metastasis and so on. So there's still a large number of patients receiving radiation that will need a much better efficacy or a lower toxicity from this technology, which is widely used in oncology. So we ask ourselves the question, is it possible to increase the dose in the tumor without increasing the dose in surrounding tissue? Because if we can do that, then we can play on increasing the efficacy or decreasing the toxicity of radiation therapy. And that's how we invented this novel radio enhancer. So it is a sterile product that we inject directly into the tumor, and we inject it only once. So it's based on crystalline inorganic nanoparticle. And if we want something nano, it's because we need something which is small enough to go into the cell. But being small is not enough. We also need this product to be able to absorb X-ray and to be inert, to be non-toxic. That's why we have chosen a very specific material, which is named hafnium oxide, because that's a super X-ray absorber. How does this work? Here, what you can see is a cell where you send X-ray. And when you send X-ray into a cell, you will create some random damage into this cell. Increasing the dose of X-ray will just increase the number of random damage. On the right, you see nanoparticles that have penetrated the cells. Here, what you can see is the particle absorb the energy and will deliver around them a large quantity of energy, a large quantity of damage. So it's more than just amplification. It's delivering within the cell some hotspot of energy that radiation alone cannot do. So what are the consequences of this? If you put some energy in the cell, then you will kill the cell. You will destroy it, and you will lead to direct cell death. And we've been developing this product as a single agent in combination with radiation therapy across a number of tumors, including soft tissue sarcoma, head and neck, hepatocellular cancer, prostate cancer, pancreatic cancer, and so on. We've been showing that this product in a randomized phase 3 in soft tissue sarcoma can work better than radiation alone. We've been demonstrating that we can double the rate of complete pathological response in the overall population of the trial, even improving 4 times the rate of complete response in the most advanced patients. This has been published in the Lancet. We also recently have shown the last data coming out from our head and neck program, where not only we here talking about some of the most advanced patients and frail patients that can get chemo, so just radiation. So for those patients, usually it's not a good outcome. What we found out in our trials is we can have a large rate of complete response and a large overall response rate. We also see that we may have a strong impact on survival and PFS for those patients, and hopefully quality of life. That's why we've been designing a phase 3 that where now the design has been approved by FDA, and we hope to move forward in this clinical trial as fast as we can. I will not go over liver, but when you look at the data, they look like the head and neck data, meaning we have a strong response rate and a strong complete response rate. Now, we've been talking about the impact of this product and its ability to destroy a tumor when combining to radiation, and how can we improve locally advanced patients. We're going to add something on this physical mode of action, which could be a subsequent biological action. We were really interested to see if destroying these cancer cells with radiation plus nano will bring to a better immunogenic cell death, will bring to the trigger of an immune response. And we are proud to present today our first clinical data on this aspect. And I will give the mic to Dr. Colette SHEN to continue this presentation. Thank you very much.
Thank you, Dr. Levy. It is a pleasure to be with you all today. And I first just wanted to motivate a little bit about the reason why we're excited to participate in this study, and then I'll go over some of the initial data from this phase 1 trial. Next slide, please. So in general, when we look across the spectrum of cancers, we think about the way that they've responded to immune therapies. And I will say that the development of immunotherapies has been one of the most exciting developments in cancer treatment in recent decades. However, when we look across the spectrum of all cancers, the majority of cancers are kind of what we see on the left side of this graph. We think of them as more immunologically cold tumors, those that have not really responded well to immune therapy. And that's in large part because when we look at these under a microscope, they may look like this image on the bottom left, where there really isn't much infiltration of immune cells. There's a small subset of cancers, those that are on this top right of the graph, that are thought to be a little bit more immunologically hot tumors, or those that may, when look under the microscope, may appear more like this bottom right image, where there's more of an infiltration of immune cells. These tumors include melanoma, lung cancer, colon cancer, head and neck cancer, and those are the ones that have been more responsive to immunotherapies, and ones that have really demonstrated some impressive long-term results in a small subset of patients. However, while even these immunologically hot tumors have had response, the large majority of even these patients do not have durable response to immune checkpoint inhibition. And so we can see that there's a significant unmet need for developing ways to augment the response to immune checkpoint inhibitors, both for these immunologically cold tumors, but also for hot tumors. This, just to further motivate the need to augment response to immune checkpoint inhibitors, these graphs are for patients with head and neck cancer who have recurrent or metastatic disease from the KEYNOTE-48 study, comparing patients who received pembrolizumab alone, which are in this top, in the teal curve, versus patients who got standard of care chemotherapy regimen in the maroon curve. The graph on the left is overall survival, and the graph on the right is progression-free survival. You can see that the overall response rate was about 20%, depending on the PD-L1 status. And we can see that while there were a vast number of patients that didn't necessarily respond to immune therapy, there was kind of a tail of patients, intriguingly, that had long-term response. And it is these patients that have gotten us very, very excited about the promise of immunotherapy. I will say that this graph is for patients with head and neck cancer, but it's also very reflective of other types of solid cancers that have been treated with immunotherapy. So these curves are very similar to patients who have had melanoma or even lung cancer treated with immune checkpoint inhibition. So just to kind of further separate these curves out, we can see that within a few months, you can see which patients really are primary resistant patients to immune checkpoint inhibitor. These kind of, those represented in this top portion of the graph in red. And those patients just do not respond to immune therapy within a few months. There's another smaller subset of patients who may have initially responded to immune therapy, but then subsequently developed secondary resistance to checkpoint inhibition. And then finally, there's a very, very small percent of patients, less than 10%, that are considered long-term durable responders to immune checkpoint inhibition. And it is these patients that have gotten us very, very excited about the potential of anti-PD-1 therapy. However, it is this type of response that needs to be expanded to a larger proportion of patients. And so that's where the need to develop additional approaches to augment the response to checkpoint inhibition comes in. So just to summarize the rationale for combining NBTXR3 with anti-PD-1 therapy, immunotherapy really benefits only a small small proportion of patients. And so converting non-responders into long-term durable responders is paramount. Radiation can prime the immune response to a limited extent, and distant tumor control, or the abscopal effect, is very rarely observed in patients. And so providing a way to potentially enhance this, not only the local effect, but also a distant tumor control is key. NBTXR3 has been shown to have both a localized radiation enhancement effect, but also has the possibility to improve immunotherapy response rates through immunomodulation. So therefore, there's a high unmet need, and NBTXR3 may not only improve local response, but also distant response. So just to transition to some of the early data that we've seen in this phase 1 study, it's a combination of NBTXR3 in combination with anti-PD-1 therapy in patients with advanced cancers, and is being conducted at several centers across the US. Next slide, please. So this study, 1100, is being conducted in 3 cohorts of patients. The first is patients with local regionally recurrent or recurrent and metastatic head and neck cancer. These patients are amenable to reirradiation. These patients have had previous radiation. The second is patients with lung metastases from a cancer that is indicated to receive anti-PD-1 therapy. And the third is patients with liver metastases, similarly from a primary cancer type indicated to receive anti-PD-1 therapy. In all of these 3 cohorts, patients may either be previously anti-PD-1 therapy naive or non-responders. So in terms of naive patients, again, these are patients who have not received prior anti-PD-1 therapy. Patients who are resistant to anti-PD-1 therapy either have received prior anti-PD-1 therapy and meet criteria consistent with primary resistance. For example, those who have had between 6 weeks and 6 months of exposure with a best overall response of progressive or stable disease. And then patients who have received prior anti-PD-1 therapy and meet criteria for secondary resistance. Those who have had prior anti-PD-1 exposure for at least 6 months and disease progression after a best overall response of complete or partial response while still on active therapy. Just to review first the anti-PD-1 naive patients, there have been 2 patients that have completed the initial portion of the therapy who were previously anti-PD-1 naive. Both were in the head and neck cohort. So this first patient was a patient that we treated at UNC. He had a previous hypopharynx head and neck squamous cell cancer treated with chemoradiation and had a recurrence in a lymph node in his neck. He previously, as I mentioned, was anti-PD-1 naive. He received SBRT radiation to his recurrent lymph node in his neck, and then following radiation began pembrolizumab. He has had a confirmed complete response lasting over a year and is currently continuing on pembrolizumab for this time. He had 1 unrelated adverse event prior to beginning therapy treatment and no other dose-limiting toxicities. The next patient was a patient who was also in the head and neck cohort. He was previously P16 negative head and neck squamous cell cancer, had a recurrence in the base of tongue, and underwent radiation SBRT to his recurrence in the base of tongue, followed by nivolumab. This patient did have 4 anti-PD-1 related and 2 potentially study treatment related grade 4 and 5 serious adverse events. And so this is the only patient who has had a grade 5 event on this study. As I mentioned, he was previously anti-PD-1 naive. It is unclear if this was related to PD-1 therapy or potentially to the NBTXR3 therapy as well. And so because of this cohort for the head and neck patients has been expanded to include additional patients. And this patient did have an unconfirmed partial response to therapy before his grade 5 event. And his this grade 5 event was due to pneumonitis. In terms of anti-PD-1 resistant patients, for the sake of time, I will probably just review 1 patient from each of the lung and liver cohorts that we treated at UNC, but there are slides for all the other patients in case we have time to go back to those later on. So if we can go to the next slide for patient 5. This patient was a patient who had PD-L1 positive non-small cell lung cancer with lung metastases. He previously had not received radiation, but had received pembrolizumab with a best response of progressive disease. Someone who was considered a primary resistance or a primary non-responder to anti-PD-1 therapy. He was treated with SBRT to one of his lung metastases, followed by pembrolizumab. He has had an unconfirmed partial response at both the radiated injected lesion as well as at 2 nodal sites that were not injected with MBTXR3 and not irradiated. One was in an AP window lymph node, and one was in an inguinal node. He did not have any adverse events or any dose-limiting toxicities. He did unfortunately come off study because he wasn't able to continue coming to our main center for study treatment, but is continuing to receive pembrolizumab at a community hospital and is alive. If we can go now to patient 13, who is treated in cohort 3 liver metastasis group. This is a patient who had PD-L1 positive, P16 negative, head and neck squamous cell cancer with liver metastases. He was previously radiation naive, but had received pembrolizumab with initially a complete response to immunotherapy, but then developed secondary resistance. He was treated with SBRT to his liver metastasis and then began pembrolizumab following SBRT. He has had a confirmed partial response at his liver metastasis. He did not have other distant sites that we were following for response, and so his primary liver lesion has had a robust partial response, and he's not had any adverse events or toxicities from study. If we can now go to the summary graph for all the patients, we can see that for the anti-PD-1 naive patients, both of which were in the head and neck cohort, both had partial responses, or at least a partial response. One has had a complete response for over a year. The patient who had a partial response, unfortunately, was the patient who passed away from a grade 5 pneumonitis. When we look at the anti-PD-1 non-responder patients, we can see that the majority of them have actually had a response in their tumors, and so at least stable disease or partial response in almost all patients. You can see one patient kind of had what looked to be potentially initial progression, but then response, and we can discuss that in a little bit as well. But otherwise, the rest of the patients have had some response that could either be considered stable disease or partial response by RECIST. Next slide, please. So if we look again at this graph on the left from Keynote 48, looking at the proportion of patients who standardly have had either primary or secondary resistance to anti-PD-1 therapy, you can see that in this study, in our study, 6 of 7 patients who were anti-PD-1 non-responders have experienced tumor reduction, and 3 of 4 patients who had non-injected, non-irradiated distant lesions have also had response. And so these are patients who might have fallen into this category of these primary or secondary resistant patients in this curve on the left. Of the patients who previously were anti-PD-1 naive, those 2 patients who potentially could have responded to anti-PD-1 therapy alone, although had not had that yet, both of those responded to treatment with at least a partial or not, if not complete response. And so when we look at these a little bit more closely at these patients who had distant sites that had response to therapy, we can see that in this first patient on the left, he had response both at the MBTXR3 injected and irradiated lesion, but also at 2 distant lymph node sites, but all of those were partial responses. The lymph nodes were actually complete responses. The graph on the middle graph shows patient who had what looks to be potentially progression at the MBTXR3 injected irradiated lesion, but a partial response or a near partial response at the distant lesion. And then the patient in the graph on the right also had what looks to be possibly progression of disease at the injected treated lesion, although I think in both of these cases it's possible that that could be pseudo-progression of the treated lesion, and then had either stable disease or partial response of the non-injected distant lesions. Looking further at this patient on the, sorry, if we can go back one more curve. one more slide. This patient on the far right graph, this patient initially appeared to have progressive disease, but then eventually had response. And so we think that this patient potentially had a delayed tumor regression about 5 to 6 months after initial treatment. Next slide. So just to summarize, tumor regression was observed in 8 out of the 9 anti-PD-1 naive and non-responder patients. In 3 out of 7 patients who exhibited resistance to prior anti-PD-1 therapy, the combination of NBTXR3, SBRT, and anti-PD-1 therapy resulted in overall partial response. Treatment has resulted in prolonged complete response in a previous anti-PD-1 naive reirradiated head and neck squamous cell cancer patient. The administration was feasible and well tolerated in all 4 patients treated in the lung cohort, 2 patients treated in the liver cohort, and 3 of the 4 patients treated in the head and neck cohort 1, with that 1 patient who had grade 4 and 5 events. And this patient had these events that were related to anti-PD-1 therapy and possibly related to NBTXR3, which is why we are continuing to look at this cohort further. And I will now pass this to questions to Dr. Weiss and Dr. Welsh for discussion.
Great. Hey, can you hear me okay, guys? Yeah, great data, really cool to see that. So thank you for presenting it and taking it through. You know, I'll just give one perspective. So I'm a thoracic radiation oncologist, and I really focus on immunoresistance and checkpoint resistance. So I see a lot of patients in that demographic and run trials in that area. So one thing I'll just comment on is it's kind of tough to evaluate the irradiated lesion using RECIST criteria. It's not the best criteria for that because a lot of time the lesion, as we know in radiation oncology, gets smaller than fibrosis and stays there. But you know, the durable local control will be what we're interested in. But the really profound thing is the response outside of the radiated area. And you know, that's just really telling about the mechanism and how it's working. Just as a bit of background, so my lab works a lot on PD-1 resistance. So we developed the PD-1 resistant model, and I've tested probably 35, 40 agents in PD-1 resistance model in mice. And you've probably tested about 5 intratumoral type therapeutics, TLR9, STING, and LRP3, all of those as well. But this nanoparticle was probably the best thing that we had in mice for producing systemic abscopal responses. So when we started studying it, we really thought it'd be something really for local control and help on that side of the demographic. But once we started combining it with the PD-1, we were seeing systemic responses that are just really profound. So I think what really we're seeing here is when you're killing the tumor with the nanoparticle inside of it, it just makes a much better vaccine than when you kill a tumor without it. So it's making a much better vaccine, better interferon response. And that's why the PD-1 is now working, because the PD-1 is addressing these exhausted cells. And if they weren't stimulated and activated in the first place, there's nothing really to address. So radiation kind of stimulates a new batch of them. Anyways, in mice, we saw really nice abscopal responses. And I don't know if we have the data in here or going to show, but one of the coolest things we found is memory, long-term durable memory, which in the immuno world is kind of one of the holy grails, because if you get long-term T cell memory, you don't have to keep giving the therapeutic, right? The T cells are persistent. And that's, you know, kind of the big thing about cell therapy, why cell therapy is so hot right now, because they could have long-term memory. But anyways, this local nanoparticle in one tumor is producing in our animal models long-term memory, and we re-challenge and we don't see anything. So it's really cool to see the clinical data validating the systemic responses. So congratulations.
Does anyone have questions?
Quiet crowd. Yeah,
Dr. Bach, you're on mute, so that keeps you quiet. I don't know if you were trying to say something.
I'm sorry. I was going to say maybe we can hear some of your commentary first, and then I think questions will start coming in.
So I hadn't really prepared commentary, but let's go off the cuff and provide a little bit of recent historical perspective on what we expect in similar populations. So, you know, when you look at small data sets, and I will confess we're a relatively small data set, you need to look in as granular fashion as you can at the characteristics of the patients if you're going to try to make that forbidden but omnipresent cross-trial comparison and try to put into perspective what happened to patients. So thinking about the data sets we have, right, this all started with Keynote 12A and 12B. And those were selected patients who were treatment naive, and we got a response rate of about 16%. Fast forward to Keynote 48, and you're not looking terribly better, right? Dr. Shen showed you the graph of the 3 characteristics of patients. Those with who never have a response, right? We're not supposed to talk about the left side of the curve, but let's confess between, I don't know how many friends on the call, it looks like Niagara Falls, unfortunately, right? Most patients don't benefit. That's about 80% of patients. About 10% falling into that medium category where they derive some benefit and then lose it. And then 10% or so that are really what make this class of drugs wonderful, right? The durable control. And, you know, I believe we treated the first human being with head and neck to ever get Pembro at UNC, and he's still alive and well. I don't know how many years later now, 7, 8 years later, from Christmas Tree PET when he went on MK3475, now known as Keytruda. Unfortunately, that's only about 10% of patients. So the first question is, if you say, okay, what's our population? We're actually looking at a pretty adverse population where you would not expect these kinds of results, right? So you're talking about the population that's in that 80, 90% who either never had a response or have lost it. Many of these patients have gotten Pembro for a decent amount of time first. Most had 6 or more cycles before of Pembro or equivalent. And what that means is that you're not seeing delayed responses or pseudo-progressor events, right? These are patients who are truly refractory, converted to be responders. And so when you look into that historic context, this is not what you would expect to see in that many patients at all, particularly those distant responses. So I'm coming around to increasingly believe that we have something here when you take that critical look to the historic data.
That's great, and actually that's a good segue, Dr. Weiss, to you know, one of the questions that came in, and then I have one for you, Dr. Kent, and that is, which you were just touching on, and you can all comment on this, and it's really about kind of how these current outcomes, with the caveat of it's being a relatively small readout population so far, how these kind of compare and contrast to those seen with other types of agents in clinical development.
Yeah, so you know, when thinking about immunotherapy with my patients, I like to make analogy to trying to make a bonfire. And I talk about drugs like pembrolizumab or Keytruda as gasoline. And the analogy I make is that if you have a small fire and you pour gasoline on that fire, you get a very big fire. But if you pour gasoline on an inert log, you just have a wet log. And so if I think about, you know, what I'm excited about in this product, it's the idea of starting that fire that a drug like pembrolizumab can then amplify. Whether you talk about R3 as the vaccine, or perhaps it's more the adjuvant, whatever you believe about mechanism of action, it is clear that it can ignite that fire in a very real proportion of patients. I am not aware of really any other public data of an agent quite doing it like this. There are certainly many efforts out there. There are toll-like receptor agonists, there are STING agonists, there have been 1 or 2 failed trials of stereotactic radiosurgery alone. There are dendritic cells infusions, there are other destructive modalities. I'm not aware of any other publicly available data that shows this into promise, that shows a preliminary positive signal.
Great, thank you. Well, I want to go back to one of the first questions that came in. This was for you, Dr. Shen. It was specifically about deciding on the dosing between the 22% and 33%.
And I think I may actually need to let Dr. Levy can discuss that as well. But I know that in terms of dosing, we actually have 3 different dose levels on this study. And so we're starting at the lowest dose level and increasing dose levels. But I know some of that is based on initial data from the dose levels that they've used for other for sarcomas and for the initial head and neck cancer study, indicating that these were well-tolerated doses. But in this study, we are continuing to increase the dose level if these initial, for example, 22% dose level is well-tolerated. And so this, in all three cohorts, we are increasing the dose level from 22 to beyond, up to 33% and higher. But I don't know if anyone else who had more input in deciding the initial dose levels would like to comment.
Or if you want to comment, Laurent.
I mean, that's for me answering question.
Okay. So go ahead.
One thing on the injection for it and the dose, I'm actually kind of a firm believer that you probably don't really even need to inject the entire tumor. So this is a question that comes up and gets thought about quite a bit. And if this is for local control and its mechanism is it has to be injected to control that tumor locally, then it creates a little bit of a challenge because that interventional radiology has to be really good, right? And so you've got to get it throughout the entire tumor and get it all injected. But now that you're seeing the immunologic benefit of the nanoparticle, it's really kind of interesting. I really don't think you need full injection even through the whole particle. And I've talked about some mouse models and things to do that. But because of the activation of the T cells, they come in and then control the tumor. And I think that's really important because it then makes it much easier. Well, it's obviously much easier to do this now. And the interventional radiologist may not have to go out and try and inject everywhere and get full homogeneous distribution of it. And that probably makes it more adaptable throughout the rest of the world and stuff as well. So I think that's the immuno side of this story with nanoparticles is Nanobiotix is just really important, and it changes the trajectory and the use of it quite substantially.
That's a great comment, and some of the same questions that say many of the oncolytic virus companies ask from replicating or non-replicating viruses, and how much kind of local destruction or spread they actually need to inflame the tumor. And so we'll go back. There's some questions about the issues of progression and potential pseudo-progression seen in some of the patients, and even to what degree that may in fact be limitations of the methodologies used. So we would like to make some comments on.
Yeah, I'd be happy to speak to that because I have, we were obsessed with the possibility of pseudo-progression when during the conduct of the 12A and 12B studies of pembrolizumab, because in the melanoma experience, this phenomenon is common, right? Thinking back to the CTLA-4 days, we had patients who had apparent progression, and then, however long that is later, 15 years later, are still without evidence of disease. Head and neck cancer is interesting for evaluating this because you can see the tumor a substantial portion of the time. And the quick answer to the question is that in contrast to the CTLA-4 experience in melanoma, when you look at the PD-1 or PD-L1 experience in head and neck cancer, it's exceedingly rare. You can certainly see some inflammation of the tumor briefly, but true pseudo-progression, as Jed and others defined in the CTLA-4 experience with melanoma, is probably almost as rare as abscopal effect with traditional radiation in the real world, which is an attempt at a joke that it's quite rare.
So hey, wait, I gotta speak up here. So abscopal.
It was you I was trying to tease, you and Colette, so go for it.
I feel like he's prodding me here, he's pushing me.
I am.
So how rare is abscopal? Radiation to PD-1 increases the response rate 100% in non-small cell. It goes from a 19% response with PD-1 to 38% when you irradiate one site. So it's a pretty, and you mentioned a little bit before about, what is the best thing to add to PD-1? So we just published in Lancet Respiratory Medicine a positive prospective study with non-small cell PD-1 or PD-1 with one side of radiation. It doubled survival. It increased survival from 8.9 months to 8.7 to 19 months. So the point is, radiation's it's a great vaccine, and it really stimulates and helps improve that immune response quite a bit. And then the cool thing about nano and where the world's going, we all know the world is multiple IOs, right? So I have trials now with 4 IO agents at the same time, and it gets really challenging because of toxicity and logistics and complications and hitting Tregs. But what's so good about Nano is it's a very simple thing to do, and it's not going to likely have a lot of competing toxicity, right? Like, you know, on top of the IPI and the PD-1 and things like that. So it's kind of a nice way to really stimulate. I like the analogy you had of the wet log and the fire, but it's a nice way to start that fire without causing problems with competing toxicity from the other IO agents out there. So I think it's a very clean, simple way to do it. Simple injection, and you're not going to have big systemic problems with it. So, you know, in the world of combos that are coming out, this is a nice way to get a benefit without more toxicity as well.
Well, Dr. Welsh, I want to pick up, you referred to Tregs, and one of the questions was actually asking kind of what specifically is known about the Tregs here, and is there anything specifically known about, you know, NBTXR3 in terms of the Tregs?
Yeah, it's a good question. So, I mean, I think about Tregs quite a bit because radiation does some good and we do some bad. And one of the bad things we do is induction of Tregs. And when we model stuff, the Treg biology in mice and humans all really doesn't capitulate. Like, we can see big differences with CTLA4 and Tregs in mice versus humans. So, you know, the question when we were working with the nanoparticle with radiation is it just helping with more of the good or maybe less of the bad, less of the Treg story? And as such, we may not see that same story recapitulated in humans because of the Tregs being so different. But I think the early human data we're seeing is that the influence on the Tregs is not problematic in terms of the response here. So I don't think it's inducing that much more of the Tregs. Although we're getting a better interferon sting immune response from it, I don't think we're getting the negative side of the radiation. And that actually could be a bit of a window and an opportunity because we know the best doses for stimulating immune responses are these higher doses, right? The stereotactic doses, 6, 8, 10 gray per fraction. The regularly conventional doses are not very good at that. But sometimes you've got to treat those because of large field sizes and, you know, tumors on critical structures. But what if you could do nano with those larger fields and lower fractionations? Could you get more immune activation and stimulation? And I think, so we have trials at Anderson that'll start looking at that question, but that brings immuno into a bit of a new space with radiation as well. Right now, all the immuno stuff that really seems to be working is the highest doses, and then the bigger fields like we do in lung and head and neck are a little bit harder to do. And so nano might have a very nice sweet spot there for like the stage 3 lung, the locally advanced head and neck. So.
Great. Good. So back to you, Dr. Shen, you know, just for clarification, I know that some of the patients you referred to were P16 negative, but there were some questions about, you know, the effect of HPV positivity in the studies.
I just wanted to first add on to what Dr. Welsh was saying, because I know it's really exciting for us as radiation oncologists to have some sort of role for systemic disease potentially. And Dr. Welsh has some really nice preclinical data that compares radiation with checkpoint inhibitor alone as a combination versus adding this NBTXR3 nanoparticle, because I think that might be one of the questions as well. You know, if radiation can do a pretty good job on its own, what's the benefit of adding the NBTXR3? And so Dr. Welsh has a lot of really exciting data that, while we haven't been able to compare that in human patients, preclinically he's shown that when you add NBTXR3 to radiation and anti-PD-1, that really increases the distant tumor response, both development of metastatic disease, but also response of distant untreated tumors. So I think that's really a very exciting, you know, exciting benefit of adding R3 to this is that systemic effect.
If I could comment a little bit on that area, you know, in standard clinical practice, we definitely see oligoprogression on PD-1, very analogous clinically to what in lung cancer and targeted therapies we've done for years, right? There are two retrospective and one prospective series in EGFR mutated lung cancer showing you can treat oligoprogression with SRS, continue on drug for the rest, and it works. And we've been doing that for some time with PD-1. But if you try to compare what you expect with stereotactic radiation alone versus with R3, I think there are hints that we're adding value here. More specifically, we have randomized data of PD-1 alone versus PD-1 plus stereotactic radiosurgery. I apologize for bringing up Memorial Sloan Kettering to an MD Anderson colleague, but it didn't work. It was a negative, maybe it's okay if I'm quoting a negative study. Maybe it's less of a jab, but I do think I think, looking at the standard clinical experience, then looking at that randomized data, it shows that this is an area that is clinically appropriate and already being accessioned, but it also shows that there is room for improvement with the addition of R3.
And just back to your question about P16 negative versus positive patients, in general, as head and neck oncologists, we tend to do better with the HPV or P16 positive patients. They respond better to standard therapies. I do think that there's a potential for these P16 negative patients who maybe have had more of a smoking history, may potentially have more mutagens or mutations in their tumors that might potentially respond better to immunotherapy. And so I think this might be a really nice option for patients with recurrent disease in that space. I don't know if Dr. Weiss has other thoughts on that as well.
Yeah, I mean, in the early developments all the way through phase 3, we looked hard for a difference by HPV biology because, it's religion in the head and neck world to state that these are discrete populations. They are in fact biologically discrete. But if you bring it back to the simple case of how I think about patients with my figurative white coat on, it actually isn't different. The biology is very different. Your HPV positive patient is a virally driven cancer. Any of us who've tried will tell you it's much easier to get a viral response than a cancer neoantigen response. Certainly we've seen that in our vaccine studies. In contrast, as Dr. Shen nicely explained, the HPV negative patient has a more perturbed biology, more similar to UV exposure and melanoma, with more a greater unique neoantigen burden, more of which may be immunogenic. How does this balance out to what we ultimately see in clinic? Their response rates are nearly identical. And so my best guess would be that while the biology may be differential for what we do when we add R3 and stereotactic radiation, my best guess is that the end clinical efficacy may end up balancing out just like PD-1s did. We'll see what ends up being true, but every time someone tries to say the rules are different, more often than not, they end up being the same.
All right, great. Please go ahead.
Can I bring up a concept real quick? So I can't believe I'm talking about something other than immuno, but what's, big picture is this can help local control, which is wonderful. This can now potentially help systemic control, which seems like the other half of the pie, which is wonderful. But there's a whole nother population, which is recurrent radiation disease, which I think is one of the areas this particle I'm actually most excited about, because that's a setting we as radiation oncologists really have a hard time, right? There's nothing to do for these people when they've recurred after high dose, right? Full dose 70 gray in the head and neck or the chest, and they recur, and we're really in a pickle, right? It's really hard to reirradiate these people. They're fibrosed. The surgeries are very challenging because of the fibrosis as well. And, we in the world and MD Anderson spend a lot of money, with $150 million proton centers to try and get a little bit better for retreatments to spare critical structures. But now you have a product that could be injected into a recurrent tumor and make that lower dose of radiation that you have to use for retreatment maybe much more effective. And I think that's a huge area, and there's really no competition there, right? We don't have any agents for that. It's basically turning up the radiation without increasing it to those other structures like kidney and spine, which are often maxed out. And so we'll have some trials looking at for reoccurrence, but that's a really profound area with almost no competition. And then the neat thing is, if this gets adopted and we show that it works, I mean, it can go throughout the world very quickly to China and India, even people treating on cobalt machines, right? On these really older machines, you don't need the fancy linear accelerator with all the latest bells and whistles to do a retreatment with this nanoparticle. You could use regular older machines. So I think that's a whole nother side too. So this particle covers a lot of gamuts, but that's a very untapped area that really there's no competition with that. It's pretty neat as well.
So I'd like to comment on that and provide some perspective on that, because I really strongly agree. As a medical oncologist, the core of my job is recurrent metastatic disease. That's not the generic patient in head and neck, but it's what my practice largely focuses on because of research interests. And we can divide these patients up roughly into thirds clinically. About a third of the patients that I see in clinic really have a local-to-local regional only problem. In that population, I am extremely frustrated to have to give patients systemic therapy with all of its side effects and toxicities for a local problem. And I'm frustrated to not be trying for cure again. In another third, I have a local control problem where I think that the local disease is a legitimate threat to the patient, and a distant control problem. And that's another sweet spot for R3 where I can have my cake and eat it too. I don't have to decide, am I going to do something local first, then a systemic therapy? Am I relying on my systemic therapy also for local control? I can shoot for both. And then the third population, I think that some of the data on the distant responses here give hope that this is something that could ignite the fire. And so this is not these are not small niche populations that we're going after in recurrent metastatic disease. These are the core populations. And then if you can bring this up into attempts to cure, as ongoing efforts are, that of course is an even larger marketplace and an even larger human need to be fulfilled.
Great, Dr. Weiss. There are two questions that are ultimately kind of related about, how NBTXR3 might ultimately be used in the practical setting of management, and it relates to the comments, I think, about one of the patients you made, Dr. Shen, about, reverting back to not able to travel to the center anymore, reverting back to community management. So the question is, how will that work given, dosing? Obviously, it's the adaptation to this is given once as opposed to, immunizations that might have to be given multiple times. But anyone who can make comments about the actual practical management there. And then the related question is, how will you decide, or what goes into deciding which of the lesions to actually inject with R3?
I'll just kind of start out on that. In terms of the practical issues, I think this is actually a very, very, a very promising approach for being able to do this, for more patients, because like you said, it's a one-time treatment in terms of the injection. The radiation is usually over 1 to 2 weeks, so it's a short treatment. Only requires potentially travel to a bigger center for a few treatments. In terms of the follow-up immunotherapy, I think eventually that will be able to be given at multiple places and community sites. For purposes of the study, we wanted to be able to keep a closer eye on the patients and treat them at our main site. But I think eventually once we treat more patients and show more safety data, I think this will be something that can be given locally. And so I think this is actually a very, very attractive option in that regard. In terms of, I'm trying to think of what your second question was, the
Which sites? How did the site?
Which sites? And for us practically, it's really been finding, basically the lesion that's most accessible, and really, whether that's percutaneously from a head and neck recurrence, or if it's something that can be accessed bronchoscopically in the lung. That's also been a nice way for us to be able to inject. I think that is one concern that folks will have, is that it requires a direct intratumoral injection. But I think in many of these cases, we've either been able to access it percutaneously or bronchoscopically in the lung. You can also access, for both liver and lung lesions that are more peripheral, also percutaneously. So I think you can really get at many lesions that way. But all you really need, I think, is what Dr. Walsh and Dr. Weiss were discussing earlier. You really just need to inject one of them and treat one of them to be able to potentially get this systemic effect.
So I want to underscore an insight raised by the question itself about the ability to infuse pembrolizumab at a community site. No one should travel to Houston or Chapel Hill from a distance to get pembrolizumab alone, right? So what's wonderful about this, in contrast, I spent a lot of time working on personalized vaccination strategies and cellular therapeutics, right? There's a lot to do around that. And patients have to essentially live at my cancer center for some protracted time for some of these therapeutics. It's a massive strength here that we can provide a brief intervention that then allows the patient to go back to the community. Everyone wins when that happens. Most importantly, the patient isn't traveling every 3 weeks or every 6 weeks to a major cancer center to get that infusion, community docs are going to like this and be more warm to it because they lose revenue if the patient is at MD Anderson or UNC getting their ongoing infusion. And frankly, for academic docs like us, I don't know how others feel, but I don't really want to give standard of care pembrolizumab. I'd like to have room for that next trial patient. So I think everybody very much wins. I'm thinking about the move from trials to actual real world use. I think this is something that my community partners would embrace more than some of the stuff that I nerd out on every day, because they're going to get their patient back.
Yeah, and especially in the COVID era, that's such a relevant statement. You know, we can't have these patients flying it's just such a risk and a hassle with COVID. It's really shifted a lot of the referrals and the stuff that we get. So staying locally is just even more important nowadays. Yeah.
So there have been a couple of questions about, you know, how the signals and, you know, in this early readout kind of compare to other combination agents, in particular the, you know, Ipi-Nivo combinations. Anyone want to comment on that? And then I have my own related question.
So it's become religion in immunotherapy for solid tumors to combine everything with the PD-1 agent. And having written some of the intro sections for these protocols, it's really easy. It's really easy to justify why anything should work well with PD-1. But outside of melanoma and maybe frontline non-small cell lung cancer, I challenge you to find any example anywhere of anything adding to PD-1. I guess in the PD-L1 high non-small cell, there's some preliminary data, but for the most part, this has been a graveyard of trials, right? We've had several thousand efforts and mostly failures. So if you look at the existing landscape, certainly from CTLA-4, there's no competitive threat here. I wish there were. You know, much as this may be more practical than what I spend most of my time on, it's not as practical as if you could just give 2 off-the-shelf drugs. That would be nice, but it's not what's happening out there. It's really crickets. I challenge anyone outside of melanoma to find much success.
Yeah, and it's toxic. You know, the combination of the two is much, much more toxic. Back to my comment, you know, we know the future is combinations, and it's hard. You know, you add the Ipi to the PD-1 and you get a little bit more benefit maybe and a lot more toxicity. So the nice thing about the nanoparticle is really you don't get much of any systemic toxicity. So that's a pretty unique aspect.
Well, my question would be, you know, with a caveat as Dr. Weiss indicated that a lot of the combinations, and we should just note that right now, I believe, including preclinical, the latest data from CRI says there's something like 4,000 IO drugs that are being pursued across, you know, multi-thousands of you know, studies. So it's a lot of effort going into these combinations. If you were to hypothesize about kind of the ones that you're aware of, ranging from, you know, Nektar's 214 to, you know, various range of bispecifics, co-stimulatory agonists, et cetera, is there another type of mechanism that would make sense to you to combine? So taking R3 plus a checkpoint inhibitor and plus agent X. Is there some other MOA-X that you think would add to the fire, to go back to Dr. Weiss's analogy?
Well, one comment on that, you know, there's a lot of drugs that are out there, but I mean, the main staples of treatment are still chemo, radiation, and surgery. And, radiation, I think you said 50%. I actually hear 70% is the number I hear about treated with radiation. Radiation's a staple, it's integrated in there. And this is the one immuno that really makes radiation much, much better. So while it is challenging to get a new therapeutic in the clinic when radiation's already used so predominantly in so many areas and embedded, it's a little bit easier to integrate with that because that's kind of the one. And then your comment about what you could integrate and combo it with. So we do, one of my things that we work on a lot is low dose radiation to modulate stroma and pull in immune cells. So we have animal work with that, and human trials will test it with that. And so what that does is if you look at the nanoparticle with the radiation in the main tumor, it makes a great vaccine, stimulates this immune response, but those T cells have a hard time getting through solid tumors, and hence why cell therapy in solid tumors is a challenge. So the drugs that help that, so we're using low dose radiation for that, but the things that hit the myeloid cells, there's a lot of interest in things that change polarization to M1, and that's kind of the rage right now. There's a lot of talk about that. And then the other thing we're also hearing about is more TIGIT and things like that that also help for exhaustion. And so those drugs will actually probably complement nano quite well, because nano will help with the tumor getting irradiated, and then those other solid tumors that'll help adjust stroma and T cell exhaustion. So the two main things I see going forward now in the systemic immune front are like the macrophage polarization and exhaustion, things like TIGIT. Those I think complement nano pretty well in terms of mechanism.
What about some of the chemokine factors, et cetera, that help to propagate the CXCR4, CXCR12, et cetera?
Yeah,
Could you repeat that? That sounded a little.
Oh, I was asking
about the interleukins.
Yeah, or chemokines, CXCR4, 12, et cetera.
Yeah. So I've had like 5 teleconferences on this topic from all these companies. So so if you look at the most important thing for immune response, and certainly immune radiation response, we keep finding the absolute lymphocyte count again and again, right? If you don't have the immune cells, the PD-1 drug is not going to work, right? So for the analogy with the log, right? If you don't have that log to even catch fire, if there's no wood, then it doesn't matter. So the ALC just keeps coming up again and again and again. So we have a lot of papers on that. And so these companies now with IL-2, IL-15, IL-7, they're all talking to us about if that agent can fix the problem. So maybe it can fix a checkpoint resistant patient already and give them some more immune cells, but particularly people with radiation depletes so many of the lymphocytes, particularly large field radiation, not the stereotactic that we talked about, but the large field radiation kills these lymphocytes, which then make it harder to work. And so these agents like IL-2 and IL-15 could really actually help there quite a bit by increasing those immune populations and then making it work better. So yeah, there's been a lot of interest on that recently, because the radiated populations they lose the lymphocytes. So it's actually kind of an enriched population that will probably do better from these interleukins. And I think it would just make nano even work better.
Great. Okay. I think we're coming to the end of our session. Any kind of final either comments by any of the three of you, or questions for your peers amongst you?
Yeah, I'll just say, it's exciting on the radiation side to finally have an agent, right? We feel like the med-oncs get all the cool stuff. They've got all the big advances lately in genomics, and we still just have our photons, right? And we need to do something better. So I think this is something good, because it kind of, it empowers the radiation oncologists a little bit, because now we finally have a tool, right? The med-oncs have had the PD-1, which has done extraordinary things, and that's where the field is going with immunotherapy. But now rad-oncs have a tool to actually step up our game, which is quite exciting as well. So it's really been a neat ride, and neat to see this data starting to hit to show that story. So I think that's kind of a novelty. You talked about 4,000 new agents in the immune. You're right, but they're all controlled by the med-oncs. We've got one.
So Nanobiotix and you, Laurent, are in one corner trying to bang the drum of physics.
Yes.
So while I don't generally support the idea of giving over any control to anyone else, much less my radiation oncology colleagues, one of the things I really like about this approach is that it's off the shelf, right? So if you look at some of the most exciting things coming out of SITC, they're not that practical, right? So Rosenberg just presented their TCR TILs, and I was looking at that presentation and saying, wow, this is friggin' cool, right? I'll admit, amongst a few friends, I was a little bit jealous that we haven't done that. But I mean, if you're making TCR TILs, that's crazy, right? I mean, bringing that into practice. On the other hand, if you can get epitope spreading and clonal expansion from an off-the-shelf therapeutic that also provides you some additional local control while you're at it, and then lets your patient go to finish that off in the community, that's really practical. That's really patient-friendly.
Okay,
yeah,
great.
That's a great point. The cell therapy stuff is so exciting and just so expensive and so hard to do and so it's not going to get adopted very quick and easily, unfortunately. Yeah.
Particularly, we have that intersection of an individualized cell therapy to identify neoantigens, so it's double individualized. So, Dr.
Yeah,
Shen.
and I think I was just to say, I think the benefit of this too is that it's tumor type agnostic. So you can really, use this for any tumor type as long as it can be injected and irradiated. So I think, like Dr. Walsh was saying, we're very, very excited I think conceptually I was very excited about having this, this potential combination with radiation, but just seeing this early data has really gotten me even more excited to continue treating patients on this study. So it's very, very exciting data and really can be continued to apply more widely across tumor types.
Thank you, Dr. Shen, Dr. White. Well, Laurent, back to you.
I think we did all the work for Laurent. He doesn't have to do anything now.
Already drinking
He's drinking his
champagne.
wine.
Yeah.
He's drinking his wine, probably.
We had it all.
France now to wine, Laurent.
All right, Ricky or whoever wants to take back control.
Thank you all.
I hear Tom.
Yes, can you hear me? Yes.
Hello.
So I
Yes.
hope you enjoyed that as much as I did. Thank you all for helping us changing the world and hope to talk to you soon. Stay safe. Bye-bye.
Great. Thank you, everyone.
Goodbye.
Thanks, guys. Bye.